ये co-author, sorry, Dr. Nandini, sorry, co-author.
So good morning to all the panelists and delegates present here. My topic of presentation is challenges, success, failure in surgical management of CFEOM patients. So as we all know, it's a congenital and non-progressive ophthalmoplegia, unilateral or bilateral restrictive strabismus, which will present with or without ptosis. It's mainly due to congenital abnormal innervation of the extraocular muscles, resulting in fibrosis and atrophy. The challenges we are facing while operating CFEOM cases are multiple surgeries are needed and unpredictable outcomes because of the restrictive nature of the condition, and extraocular muscles are shrunken and fibrotic. Inclusions are inclusion criteria is all cases of CFEOM patients attending our tertiary eye care hospital in a period of 6 months who have undergone surgery is included, and family history was taken, and old pictures of the patients were verified. Complete ophthalmological assessment including visual acuity, ocular motility examination, anterior and posterior segment evaluation, forced duction test, neurological assessment of all the cranial nerves were done in all the cases, and ptosis evaluation is done wherever it is needed. And it's a case 1. It's a 4-year-old male patient who presented with bilateral ptosis, which is symmetrical, and presented with a gross chin elevation. Both eye is hypertropic 45-degree, and vertical motility is grossly restricted. There is no elevation beyond midline, and horizontal motility is grade 4 limitation is there in all the cases. Palpable fissure height in primary cases in right eye 3 mm and in left eye 4 mm. LPS action is poor in both eyes. There is no improvement in ptosis with eye spec test. And in this case, we have done both eye 8 mm inferior rectus recession, and there is cross improvement in the compensated head posture, and hypertropia is reduced. And there's the second case, a 10-year-old female child. She has a past history of surgery. 5.5 mm bimedial rectus recession was done. She presented 5 years later with consecutive exotropia, for which we have done, which is of 70 to 75 prism diopter basin. We have done lateral rectus supramaximal recession along with medial rectus advancement, and amniotic membrane graft was done. And this is a case 3, and 17 years old male who has 45-degree exotropia in both eyes and hypertropia 15-degree. In this case, we have done both eye supramaximal lateral rectus recession along with the inferior rectus recession in left eye. In this case, we didn't achieve any good surgical outcome, which shows that CFEOM has unpredictable outcome. So, conclusion, our aim is in surgery of CFEOM patient is to improve the quality of life of the patient and not the ocular alignment, since the clinical features of CFEOM are often variable and surgical outcomes are often unpredictable. As we can see in case 3, with no improvement in the compensated head posture as well as the ocular alignment in the primary position. And in case 2, operated prior for esotropia landed up in consecutive exotropia. CFEOM type 1 shows good results after surgery due to improvement in head position and an acceptable ocular alignment in primary case after inferior rectus recession as seen in case 1. Other types of CFEOM other than type 1 has unpredictable outcomes. Thank you. Hello.
What precaution do you take while doing inferior rectus recession so that there is no lid retraction post-operatively?
We should not go beyond 7 to 8 mm recession, and there will be chances of extracorneal fat prolapse and complications will be there. And regarding lid retraction,
So, because the type of the prognosis would depend upon the type of CFEOM, but so how many patients and what classification did you have in your patient? Because you didn't tell us how many had 1, 2, 3 or 4 type.
yeah, because of the restriction of slides, like 12 slides for this presentation, I have not included. Type 1 is basically both bilateral, it's autosomal dominant.
In your patients, you had a few patients. So how many had type 1, type 2, type 3,
Yeah,
type 1?
first patient, the 4-year-old male child, he belongs to CFEOM type 1 because there is no associated neurological abnormalities, both a hypertrophic gross vertical motility.
That's okay. I'm just asking what are type 1. Did you have type 2 also? Type 3, type 4 in your?
Yeah, that exotropia child where we didn't achieve the primary position, I guess, and any compensated head posture improvement, that case is CFUM type 2.
So you should have, in your result section, you should have, you can correlated your results to the type of CFEM.
Okay.
That would have been better.